some of you who joined from Europe and elsewhere. It's a real pleasure this morning to have a good friend, Colin Barker. Colin is truly an expert in both coronary and structural heart interventions. And we tend to save like the complication sessions for the end of the year because it's a good way to look back at our year and learn and think about what happened. I certainly love watching other people's complications because it reminds me I'm not the only one who has complications, Colin. So thank you for sharing yours, and thank you for spending some time with us and the fellows.
Thank you, Azim. And this has really been, these platforms and these courses have really been an excellent way for us to continue to learn and share in this unprecedented time where we can't get together in person, and really appreciate the effort you've put together here with your team. So I'm going to share my desktop. And there. You see my slides?
Yeah, we do.
All right. So as Azim mentioned, I wanted to do something maybe a little bit different where we all kind of learn from each other and some challenges. And I'm going to primarily focus on structural heart and TAVR cases, with the theme being this concept of failure to rescue, or the opposite, the ability to rescue. And it's really the learning point is it's not just one person or one team. A lot of times in the cath lab, particularly when we're taking on particularly challenging cases, you really need multiple teams to work as one unit in order to resuscitate, what's become a near-death situation. And in these, given, with all the resources we have in 2020 and into 2021, most patients should be able to be resuscitated successfully despite what can frequently be a catastrophic event. So the first case is an unfortunate 56-year-old woman who had a lot of comorbidities, but years ago had symptomatic aortic stenosis and mitral regurgitation, and had an aortic valve replacement with a 21 millimeter stentless 3F valve, which we'll look at in a second, and then had a repair with a band of her mitral regurgitation. She also had kidney disease and just had frequent hospitalizations with decompensated heart failure. It was picked up on echo that the gradients were beginning to go up on her aortic valve. And because of her decompensated heart failure, she had become progressively deconditioned to a point where she, was not mobile except for in a wheelchair. So here are the details of her operation in August 2012, where she had this 21 3F valve, which has some unique features we'll look at in a second, a repair and a PFO closure, and then a note in the op report that says really abnormal double barrel left and right coronary coming just besides the left and right coronary commissures. So basically what it looks like on CT is an anomalous right coronary that comes off just next to the left from the left commissure. So here's the 3F valve. So it is stentless. It has these leaflets that are actually equine as opposed to bovine or porcine, and was in vogue for a while because of the initial hemodynamics, but then ran into, as a lot of these valves do, early degeneration. So she had, as I mentioned, increased velocities across her aortic valve, almost reaching 5 meters per second. And with her symptoms, we were asked to consider her for a TAVR valve and valve. So here is her most recent echo showing the leaflets and short axis on the left and the gradients on the right. And you can see they're clearly approaching 5 meters per second. And the leaflets do appear somewhat restricted. So as far as case planning, one of the challenges in her was that her sinuses were fairly small and maybe not enough room to do a TAVR, frankly, or would we need to consider something like a Basilica? And so after quite a bit of review and discussion, we decided to proceed with the Basilica. And you can see here, particularly in the upper right panel, that the distance from her coronary to the valve is less than 3 millimeters. General rule of thumb, I think we follow these days, is less than 4 millimeters is somewhat riskier for coronary occlusion. And coronary occlusion, is one of the really kind of rapidly or quickly potentially fatal events that can happen in a TAVR procedure. And you can also see that the right coronary in the lower left does come off just adjacent to the left coronary. So the hope is that with a single Basilica procedure, we would prevent any issues around the potential for coronary occlusion. So after quite a bit of effort, this is actually the Basilica procedure. In addition to the Basilica, we did decide to protect the coronary arteries. And just what we did was, yeah, go ahead, sorry.
Could you just explain, because not everybody who joins this are structural
of course,
what a Basilica is?
Yes. So a Basilica is a intentional laceration of either a bioprosthetic or native leaflet. And the idea, and Azim, I'd love to hear your thoughts. I am actually very skeptical, not because of just this case, but because of a lot of experience, not a lot, but with several cases of this. The idea is that you tear the leaflet and therefore free up the potential for creating this covered stent that would occlude the ostia of the coronary arteries. Early kind of bench and modeling work showed that it was potentially very successful and helpful. The group in Washington and Atlanta, the guys in Emory have really kind of pioneered this and taken the lead on it. It's very tedious. It can take a long time, and not only for the interventionalist, but also for the echocardiographer. And what you have to do is take the bare end of a wire and hook it up to some RF energy and pierce through the leaflet, and then snare it, reshape it so that it has almost like a cutting edge to it, and then again with radio frequency tear the leaflet. And so going in, you have to appreciate that once you do this, you're going to create severe either aortic or mitral insufficiency, whichever valve you're working on, and that this may or may not be that well tolerated. We haven't had a whole lot of hemodynamic issues after we've done this procedure a handful of times, and I know the guys in Emory have the same experience. I mean, they'll create torrential MR, in order to get a valve and valve or valve and ring or valve and MAC, and patients for one reason or another do seem to tolerate it temporarily. So that's the idea here, is an intentional tearing of the leaflet, specifically the leaflet here in the left coronary cusp, in order to prevent obstruction to the coronary arteries. So on the right, on the left is the echo image of the piercing of the leaflet, and on the right is the snaring of it, of the wire, and then creating a loop and then reshaping the wire to sort of be like a mini blade, a radio frequency blade. And here's the aortic insufficiency you see developing as we lacerate the leaflet. So despite, I guess, just sort of being a pants and suspenders approach, we decided to, as I mentioned, protect the coronary as well. So here you see the TAVR valve going in, and then a stent just hanging out in the left main into the LAD in case we run into trouble. So the valve's deployed. The hemodynamics, though, were mildly improved, I would say. We still had a mean gradient and peak velocities approaching 3.5 to 4 meters per second. And we knew, looking back at 2012 and 14, her postoperative echoes really had no significant gradient. So this was not a patient prosthesis mismatch issue. And there was potential to get her hemodynamics back to closer to baseline or normal. So on this angiogram, we see that we still have good flow in the coronaries, the valves deployed, we still have a high gradient. And so the discussion here first was, should we post dilate? Which I think we all unanimously said yes. And then B, if we post dilate, should we still protect the coronary? Do we still need to protect the coronary? Is there any risk in removing the stent in the wire, or is there any risk in leaving it after we post dilate and having difficulty taking it out or deploying it? And we didn't know the answer, but we were comfortable that there was more room there than we thought. So we did actually remove the wire and stent, as you can see here, and decided to post dilate with a 22 millimeter true balloon, which is a pretty robust balloon that you can get a lot of radial force, and you can see it really nicely expanded that portion of the valve that was sort of squished right around where the sewing ring is of the 3F valve. And you can see on the right, the hemodynamics did confirm that the post-dilatation was successful and that the gradients had essentially gone away. Now, with that, after the valve went in, her heart essentially stopped beating in about 3 minutes. And so there's only a handful of things that can do that. But obviously, if you ligate or occlude someone's entire coronary blood flow, which is what happened here because she had those two arteries coming off the left coronary cusp, her EF dropped, pressure dropped, and she arrested on the table. And so that's on the left is the immediate post-implant TEE. And then on the right is about 10 or 15 minutes later, and you're seeing basically cardiac standstill with stasis. And that's believe it or not, that's the left atrium, the mitral valve here, and left ventricle. And you're just seeing blood not moving. So we did a couple of things pretty quickly. And one of the things I have become a fan of, if needed, this hopefully doesn't become routine practice, but is the idea of putting someone on ECMO as well as an Impella in to vent the LV. And unfortunately, we've had a fair, we've done about 5 or 6 of these cases in the past year, and we've been able to successfully resuscitate them and at least get them out of the cath lab and most of them actually out of the hospital. So that's what's going on here. The patient's now put on ECMO and Impella, and you can see the first shot here of the coronary artery after wiring was occluded. This was a pain to wire. We ended up wiring it with something you don't usually put in the coronaries, which is an 03500 glide wire, because we just could not get in there with standard equipment. And part of it had to do with, if you remember the 3F valve, it has these really tall leaflets. Despite the Basilica, which was the intentional tearing of that anterior leaflet, we still had issues with obstruction to the coronaries. And because both coronaries came off roughly the same spot, we essentially had no coronary blood flow. So we were able to eventually get a stent in there on the right-hand side, and you can see, appreciate, kind of a normal appearance of her left, but then her huge right coronary artery wrapping around and then going to the posterior part of her heart. And you can see this is once we got the stent in, her ventricle all of a sudden, maybe no surprise, but really kicked back to normal. And in fact, She obviously was a little dry here, but her LVEF is back to where it was, which was normal to begin with. And here is what the valve now looks like 3 weeks post TAVR, and her ventricles continuing to work well. She did okay. She certainly struggled. The third day after the procedure, we were able to transition her to just a balloon pump. And a week later, the balloon pump was removed and she was extubated and then transferred to the step down. I mean, she lingered in the hospital for a while, as you could imagine, but survived this event. And, I think a big reason for it is that we did have multiple teams who work well together. We're able to get her quickly on support, get perfusion restored to her coronaries, and then with the critical care and anesthesia team, recover her. And, it really requires, I think, a huge commitment from everyone involved. But, ultimately, can resuscitate what was, 5 to 10 years ago, this woman would not have made it out of the cath lab, as far as I'm concerned. And, these days, with all the resources we have, are able to do this. Now, as far as learning, I don't know what you think, Azim. I'm a little skeptical about Basilica in general. Next time and obviously we debriefed on all these cases, I would have left the coronary stent and probably just gone ahead and deployed it, regardless of how things looked, just because it was so crowded in there with those two coronary arteries, the really tiny distance between the ostia, the coronaries, and the valve frame. I think we probably should have just left it and then deployed it. The concern about leaving it in post dilating, I don't think that would have been an issue. We would have pulled the guide back, left the wire and stent down, and still been able to deploy it, I think.
Yeah, Colin, I would tend to agree. I think, this case highlights a couple of issues or a couple of learning points. I guess the one that I continue to tell the fellows is, this is what makes structural so different to coronary intervention, because, when you have an occlusion with a coronary intervention or perforation, you usually have some time to deal with it. When this kind of complication happens with structural, you don't have a lot of time. So unless you have a good team and and the team understands what to do in these situations, and you can put a patient on ECMO really quickly, this patient would never have survived unless there was a great team around you in the cath lab. And when you said ECMO, everything just started moving in sync to get this patient on ECMO really quickly. So I think it highlights that. I have a similar reservation about Basilica. It's very complex to do. It can take sometimes a couple of hours. Most of the cases I've considered it need double Basilica, so they need the right and the left, and that makes it even more complex. The only thing I probably would have done different here, Colin, to be quite honest, is we tend to leave the stent in until after the post-dilatation, okay, and make our decision there. And what I tend to do is I use a guide liner. So I'll actually leave the guide liner in the left main, okay, because it's so soft, the guide liner or telescope, whichever one you prefer, so that even if you release the valve, you post-dilate, it's small, it's in a large left main, it doesn't dissect. And if you decide for any reason you're not going to implant the stent, you can just easily pull it into the guide liner, right? Mm-hmm. So it just makes it a little safer. So that's what I've been doing almost as standard with coronary protection.
Yeah, that's a great idea. And I think that's exactly what we should and will do moving forward if we have to sort of take on cases like this again.
Yeah, hopefully there are not too many of these.
I'd be happy if I don't do any of these. So this is another example of just, this is pretty unique, but there's some interesting things that happen here. This is an 81-year-old who actually was doing fairly well, but had noted to have aortic insufficiency and some MR. And despite being fairly functional, the degree of the regurgitant both valves, aortic and mitral, had progressed to a point where he met some criteria to get surgery. So in March of this year, he had a repair of his aortic valve where they essentially resuspended the commissures and then replaced his ascending aorta and repaired his mitral valve. He got through the surgery pretty uneventfully, but afterward just had issues with really decompensated heart failure, recurrent pleural effusions, in and out of the hospital, and actually got transferred to our hospital, not to us, but to the advanced heart failure team, who really, kind of have limited options with an 81-year-old who just had, major open heart surgery. So it turns out on the subsequent echocardiogram, he had recurrence of his aortic insufficiency and now had severe TR, likely, from high pulmonary pressures. And his ejection fraction and LV, which at base pre-op were preserved and normal in size, had really become dilated. And one thing we've started to do, there was a question of, was this all just ischemic? Did he take a big hit during his during perioperatively? And so one thing we've started to do almost routinely is, while we're getting our whatever structural CT scanning, we'll add on the CT FFR with heart flow. And this we still obviously could cath somebody if need be, but for the most part we're been pretty happy with this. And so on the left is not our patient. This is just an example of someone who had some obstructive lesions. So the color codes, if you haven't used CT FFR with the heart flow package, you want blue in your coronaries. You don't want red or orange. That is a sign of decreased perfusion. And here's his. So he did not, his coronaries looked fine. Now we still will cath people, particularly if we see something like on the left. But if we see really normal flow, we're pretty comfortable and confident that we can just proceed without a further coronary assessment. And here's what his heart looked like. So it's clearly dilated and hypokinetic, his LV. He has that mitral valve replacement that seems to be doing okay. And he has significant AI. It's hard to quantify here. We'll get some more information. But it seems that the AI is probably contributing a fair amount now to his dilated and LV, decreased EF, and more importantly, his decreased functional capacity. So here's TE images, showing a little bit more clearly the aortic insufficiency, and it was quantified here as severe. So the challenge here, and Azim, you and I have learned, I think, the hard way in doing aortic insufficiency cases, is that there's no generally, an isolated AI. These aren't a result of calcific disease. They're still compliant annuli, and sizing them or deciding on what valve is a challenge. There's experience with all of the valves, I think, in aortic insufficiency. And I think there's definitely a publication bias. A lot of us haven't shared our experience when we've tried to do these. I think the success stories are the exception and not necessarily the rule. There were and still are, some hope in dedicated devices for aortic insufficiency. They've come into some hookups in their initial experiences, but people are still trying. And so our challenge here was, should we do it? And I think, it was a little bit aggressive, but there was really an ask from our advanced heart failure people, because there was really no other option here. LVAD transplant, those kind of things were sort of off the table for various reasons. So here you can see his annulus measure is actually kind of small, around 360 for the area and 68 for the perimeter. And you can see his sinuses are big, which go along with isolated primary aortic insufficiency. And you can see there's just zero calcium here. So we sort of went back and forth about which valve, how to do this. Surgery was off the table. I mean, this was, I think, July. So he was like 3 months post-op. And, my comfort here with a Medtronic valve was pretty high, but a little concerned is that's where our most our most experience with AI has been with Evolute, and have had issues with it migrating or embolizing. I like the idea of just putting in a big, a much bigger than would be sized here, Edwards valve. But of course, the issue with the Edwards valve is once you put it in, you're committed. With the Medtronic, you can at least deploy it 80% and look around, see how it behaves, see if you think it's going to be secure. But this is a little bit now historical. The other option at the time was a Lotus valve, with the idea that we could put that in, and that valve, one of the upsides to it was you can entirely deploy it and take a look and do it with a tug test. And if it looks secure, be a little bit more reassured that you're going to have a safe result. So we did actually decide to go ahead with a Lotus valve, a 27 millimeter one, hoping that we would get some sign that we have a safe, secure result. So there's an aortogram on the left just for lining up the annular plane, but as well as it just confirmed, it wasn't necessary, but confirmed severe aortic insufficiency. And on the right is where we've deployed the Lotus valve to a point where the aortic insufficiency was actually resolved. And now it was more a question of securing the valve. And in this case, you can see this is a pretty aggressive tug. The valve is in place here in the lower half of the frame. And this is tugging on the catheter to see if this valve would either pop out or move. And, several kind of iterations of this, different, a couple of us took turns just so we were convinced that this was going to be something that was going to be safe. And of course, literally when the last sheathing aid came off, the valve flew up into the ascending aorta. So unlike the last case where the patient just rapidly deteriorated hemodynamically, in this case, the patient was entirely stable. So a much different situation, but one that could become problematic if we lost wire access to the LV, if the catheter and wire came back. And you can see how free that valve is. If it inverted, and remember horror stories about this in the early Edwards days, if it inverted and got lodged somewhere, it would essentially be like clamping the aorta. It would be occlusive. So now the question was, he was not a surgical candidate. We have this valve kind of flying around in the ascending. He still has now torrential AI, probably even a little worse now. And what are our options, as far as rescuing this situation? And it's a challenge. There were several challenges with this case. It's not like there's anything easy to snare onto here to park this valve in the descending. It's not, it doesn't have anything that you could really grab a hold on. And we had a contingency plan ready anyway, in case this happened, in that we would, if for one reason or another, we didn't predict this, but if for one reason or another, we didn't like the way the Lotus was sitting. We did have the Medtronic team and valve in the room and available as well. This obviously was a little bit more than we had anticipated. So we went ahead and got the a 29 millimeter Evolute ready. And again, totally different scenario in that the patient's totally hemodynamically stable for now. And the issue is going to be moving forward. There was even discussion in the room, should we just abort, let this thing end up where it is? And we tried, and it's not going to happen, which I think was reasonable. But since we had the team in the room, we were able to go ahead and get a Evolute in there, and it actually sat very nicely, and got rid of the aortic insufficiency. And then just with some luck, we did the pigtail catheter had grabbed a hold of the Lotus valve similar to a snare and pulled it down into the descending thoracic aorta. You can see here on the left image where the Evolute valve is here in the aortic position and treated the aortic insufficiency, and then the Lotus valve is here in the descending, and there's the transthoracic echo. And here it is with color showing that the AI had resolved. And this did turn out to really be, aside from just all the deconditioning, this was the hemodynamic lesion driving this guy's symptoms, because he actually did it much better than the last case. He was out of here in about a week, and at a 30-day follow-up, was home and independent. I mean, his EF hasn't recovered, but at least clinically, he's improved. So that was that case. I think, a lot going on. I think one of the major learning points here was how pre-procedurally we had gone through we thought we had gone through every potential complication, but had no idea, did not predict this. We thought we had a win with the Lotus valve after tugging it and pushing it and pulling it and taking turns. And it's one of those things, and Azim can speak to this as well. It's very humbling being in the cath lab. One thing I always preach to the room is don't pop the champagne until the patient's out of the room. Just because you got a valve in there doesn't mean something else is going to go wrong in the next 3 or 4 steps. And, this was totally deflating. The whole room just kind of went, ugh, when we saw that thing up there. And the anesthesiologist, who's great, asked us if we meant to do that. And of course not. That was not intentional, because he's sitting there holding the TE probe saying, I think the valve is flipping around in the ascending. But despite that, had a contingency plan and proceeded, which I think was which ended up being the right case here, rather than throw in the towel and stop and say, we tried, it didn't work.
I'm getting palpitations just watching it.
It's painful.
No, because this has happened. I mean, if you've done enough valves, this has happened to all of us, what you're showing. So it's not, but just when you see it again, it's just, deja vu.
Yeah, it was.
I'm going to let you carry on.
So disappointing.
Oh, man. Oh.
Anyway, so I just have one more quick one. Along the lines of this is just a different approach, and I think I may have shown you this before. This is just a different approach to a similar problem as the first case. So this is an 83-year-old female with severe symptomatic aortic stenosis with syncope and myelodysplastic syndrome. And here's her workup. So she has a pretty small annulus, with an area of 310 and a perimeter of 64. And with that, her sinuses were sort of borderline between 26 to 27 millimeters. So not prohibitive, but close, particularly on the left. But her coronaries, her coronary heights seemed to be okay. And the thought was we could probably get away with the valve here without having to worry too much about a coronary occlusion. And frankly, we just briefly discussed, the issue of the sinuses, thinking this is not going to be a problem. We'll be able to deploy this valve. We'll go with an Evolut and an 80% if we still have good coronary flow. We'll be happy. And so here's the post-implant. The valve's a little high, but on angiography, we're pretty happy that we can see good coronary perfusion. Everyone pats himself on the back. Let's get out of here. Get on to the next task of the day. But I think what we learned here, so we routinely give protamine. And after the protamine went in, the blood pressure dropped a little. There's always this, well, it's just the protamine. But then the anesthesiologist said, well, I'm bolusing him with epi and neo, and she's still not doing well. What's her ventricle doing? So on the left is sort of the pre and peri-procedural ejection fraction, but then on the right, you can see her ejection fraction is essentially dropped again. She's not at a standstill like that first woman, but in extremis, and then the kind of giveaway were the 6 or 7 millimeter ST elevations on the telemetry monitor. So in this one, this was at least a year or two ago. One of the things we had done previously, and this was a native valve, so not unlike the first case, this was a native valve with a coronary occlusion. One of the things we had done previously, and this is before, Basilica and all this stuff, in a native valve, was actually just quickly go in and intentionally snare and pull the valve out. At least to the ascending aorta, because that will immediately give you perfusion to the coronaries, and then you can decide, how to manage it from there. So that's what we did. We had already taken the sheaths out, so had to get access again, go back in, snare the valve, pull it up, and her hemodynamics almost immediately recovered, where she had now clearly perfusion back into the coronaries, ejection fraction back to normal, and now the decision is how do we treat her? Do we stop? She did not have a lot of aortic insufficiency. Her her aortic stenosis was now moderate, from a what would be considered an aggressive valvuloplasty, or do we put another valve in, a smaller valve or a same valve in a different position? So what we did is went ahead with angiography again, and here's her ejection fraction after that, is put a second valve in, but just a little deeper. And, since these TAVR valves, the Evolut valves, are sort of hourglass shaped, if they're a little deeper, the risk is a permanent pacemaker. But when you start getting towards the narrower portion of the valve frame, you're going to have more room for perfusing the coronaries, which is what we did here. And so you can see there's a couple little tips and tricks here. One thing, when you do go in with the second valve with the Medtronic, they'll interact a fair amount. So you can see we kept the snare with tension on the first valve in order to avoid it from being pushed down into the aorta and the LV. Deployed the second valve, and this time after protamine waited and did a root shot, and confirmed that we still had coronary perfusion. So we went ahead and got out, and she, it's amazing how resilient some people are. If you looked at her, you would have had no idea she went through all this. But again, the team, it was recognized what was going on. The team acted quickly. We didn't have to put her on some huge support. We just snared out the valve. And part of the reason for the snaring of the valve is, and Azim, you can speak to this is just better than I can, but it can be hard cannulating coronaries, particularly years ago when we were just sort of putting these valves in without much thought as far as positioning the catheter and the commissures and the sinuses. but getting into these coronaries, particularly when we had a high implant like that, can be very challenging, if not impossible. So snaring it is an option, not the ideal option. There's risks of snaring. You can cause an iatrogenic type A aortic dissection, but at least gives you an out, an immediate recovery from a coronary perfusion standpoint.
So, Colin, what do you think the mechanism of the coronary obstruction was?
I think so. We kept going back to a little bit tight on the sinuses, a little bit high on the implant, and the leaflet. You know, when you now we were a little bit more sophisticated when we look at kind of leaflet heights and things like that. It was very close, even with the coronaries being 13 millimeters. It was still pretty close to being obstructive. And then I don't know if I believe it, but there was a lot of thought that with the protamine, we're creating a pretty thrombogenic environment. You give protamine, and there's already some stasis and different things going on that even just the smallest of a blood clot could have caused a problem. I don't think so. I think this was more mechanical from the high implant, the longer than appreciated leaflet, and with a lower implant, there was just more space and more room in there because there was no signs that there was any thrombus anywhere or anything embolized distally. Her coronaries looked fine, after the valve was pulled up.
Right. Let me quickly show you a similar case, if you don't mind, because it made me think of a case I wanted to show you, because I think I have a suggestion for what the mechanism is, because unfortunately these things happen to all of us. So this is a case that happened to me this year, and I think it may explain what happened to your case too, right? So I go do a TAVR, core valve as well, okay? And if you look here where I'm going to implant, looks pretty good. Coronaries look pretty out of the way, okay? And then as I release the valve, look at the pigtail, it's kind of popped up slightly, right?
Yeah.
If you look at the two pictures. I do an aortogram, but with the pigtail still down there, okay? And it looks fine, okay? Sure, there's aortic regurgitation, but it's because the pigtail's way down here, right? But coronary perfusion's great. There's no issue with coronary perfusion, okay?
Yeah.
But there's something else that's a giveaway that I missed on this picture, okay? And I'm going to come back to it. So I just want to play it again so everybody can have a look. There's something that's a giveaway that I should not have walked away from this case. So in any case, we say everything's fine. We do an echo. There's no issues. We give protamine like you. We routinely give protamine. I walk out of the room. 10 minutes later, I'm being called back to the room, okay, because the patient arrests, okay, has severe hypotension, arrests. We start defibrillating her. She goes into VF. We start CPR, and we quickly put on VA ECMO, okay? And we do a aortogram. There's no coronary flow.
Yeah.
All right. So, I mean, nothing. So similar. So I think the giveaway was this initial picture here. Okay. And I'm going to play it again. Is look at where the neosinuses are. Okay. They're up here. Okay.
Yeah.
They're above the actual coronary ostium. Okay. This coronary only gets systolic flow. It doesn't get diastolic flow.
Yeah.
Because I effectively sequestered the sinuses. And I think that's what happened in your case too.
You
go back and you look at that picture, your neosinuses, because core valve's supraannular, okay, the neosinuses, if the valve's too high or pops up, as in my case, could potentially sit above the coronary. So now you only get flow from systole, and this is why you're still seeing coronary flow here on the left, but in diastole, the valve closes and there's no coronary flow.
That's interesting. I'm sure that's it actually. Now
Yeah.
look, I mean, it's obvious once you point it out, but it looked fine.
Yeah. Exactly. I missed this. I walked out of the room. And if you look back at your case, okay,
Yeah, it was
I
similar.
bet you it's similar. You'll see the neosinuses, the supraannular valve above the coronary. And so I had to do the same thing. I snared it like you did, because that's the only thing you can do, is to snare it and get it out of the way. Difference to you, I wasn't brave enough to put in another core valve, so I put in Edwards just to be out of the way, and everything was fine. I mean, we decannulated her in the cath lab. She went home a few days later. It's amazing the resilience of these patients, but I think that's the mechanism, unfortunately, and I think it's something that we don't look at enough, but I think hopefully our two cases will encourage everybody else who's on the call who does these cases to kind of look at that a little bit better.
Yeah, that's amazing. They're pretty identical.
Yeah, no, it's terrible. I mean, I haven't had one like this happen for a long time. I'm going to let the fellows come on to the call, if you don't mind, just to see if they have any questions. So Sharon or Shun, or Manaf.
Yeah, we're all here together, actually.
Okay, good.
So I actually have a question. Thank you for the very challenging cases presentation. We always learn from the complications, so that was a great talk. Thank you. I have a question about the. So when you do a basilica, does type of surgical valve make a lot of difference? I know like 3F is stentless. Mitral flow has a skirt outside of the stent. Does type of surgical valve affect the outcome or how you approach the case?
Yeah, that's a great question. And I think as Azim and I concur, we're both a little skeptical, but generally it does matter, because there are certain valve types where this is going to become an issue. And it tends to be, mitral flow, 3F, and trifectas. Valves where the leaflets are tall and tend to be on the outside. The Edwards valves and some of the Medtronic valves, if you look at the bioprosthetic valves, some of the leaflets don't come up very high, meaning don't even come up to the top of the surgical post. So it would be more a decision, a point in your decision tree if you even had to do it. If you were dealing with a surgical valve with a small sinus, but it was one of these valves with leaflets that don't come up very high, it wouldn't be an issue. So it really just tends to be an issue. But I think we still need to come up with something better. I mean, it can take hours, and then in the case I showed, it probably didn't even make a difference. Really, I think just snorkeling a coronary stent would have been, if we had to do that case again, I wouldn't do a basilica. I would, as Azim said, now I know, I would put the stent in with a guide liner, and then at the end just have it snorkeled out, and that would have probably been fine.
The other issue when you do the basilica, right, is you can't be absolutely certain that as you pull and you lacerating, that the laceration stays in the center of the leaflet, right? It could, because of the direction of the aorta and the way the aorta and the aortic arch is, that as you lacerate, it pulls sideways too. And so you don't get a proper basilica, right? I mean, the idea of the basilica is that you take the leaflet and you do that, and you split it in half, right? But what happens if you take the leaflet and you split it like that, sideways? Okay, that can happen too. So that's kind of why there are a number of companies actually working on maybe a device that would allow you to do a basilica with a device that was more reliable, that was always in the center, and that that doesn't take 2 hours to do. That can everybody can do.
I see. Yeah, that was my question, because that case seems like it's best bang for the buck, because both coronaries are coming off the left coronary cusp. If you do a basilica and if you have a good control of what you're lacerating, it seems to theoretically make all the sense. So how much control you have with the basilica was my question, but I guess you don't have full control, I guess.
Yeah.
Yeah, I would say very little, and especially in the mitral position, it's called a lampoon, and particularly when you're doing the a native anterior leaflet, and we've done one that I can recall where we did both accesses were transeptal, and it's a total random laceration at this odd angle, right? I mean, going lateral to medial. It's not going anterior to posterior as you would think or hope in order to free it up. So there is a lot of opportunity there for innovation and improvement as we see more and more of these.
Yeah.
Sorry, one more quick question on that case. Did you do sentinel, valve in valve, a lot of manipulation of the valve,
Yeah,
embolic protection?
we did not, but now, and I can't remember if we had it. We got Sentinel over the summer, so we may not have had it yet. We have it now. We're trying to sort of, and we're also in the protected TAVR, randomized trial. So we're going to try to mostly put people in the randomized trial, but you're right, valve and valves and bicuspids keep coming up. Although there was some recent data that, I'm not as up to date on it, maybe as you are, is that the bicuspids didn't have as many strokes. So I think, our approach to embolic protection is to try to get them in a randomized trial.
Yeah. We've been using more and more. There's 2 studies out of Europe, both showing an increased risk with bicuspids. So we've been routinely now protecting our bicuspids irrespective of age, and our valve and valves and anything where we manipulate a lot or there's a lot of calcium. So Anthony Pisanello asked a question about coronary protection and asked whether the guideliner is actually engaged in the coronary during valve deployment rather than disengaged. And so Anthony, answer is yes. In the old days, before we used the guideliner, we would just have the guide catheter disengaged, okay? And the problem is that once you release your core valve, because most of these cases where you're doing this are valve and valves where you do a core valve, you release the core valve, your guide catheter is now jailed behind the stent of the core valve. And so it's very difficult to advance the guide catheter if you need to get more support, if you need to get a balloon down. So what we do with the guideline or telescope is we actually leave it in the coronary during valve deployment and even during valve fracture. It's very safe. It's only 5 French, so it's not going to cause coronary dissection, and it's very soft as well. And then there was a question from Ziad Ghazal about my case and about, I guess, Colin's case. I think they're identical, and maybe Colin, you have thoughts about this too. He says, in case of supraannular position and no diastolic flow, shouldn't we expect the problem to show immediately and not a few minutes later? Any thoughts, Colin?
I mean, yeah, I think it's variable, what someone's coronary distribution is. I mean, our first case crashed because that was 100% of their their coronary arteries. And it would be variable. Someone has grafts, switch grafts are open, which are closed, and how you occlude. But I bet you if we were in the anesthesiologist's shoes, we may see stuff pretty, that wasn't appreciated, because there is a lot going on with hemodynamic shifts at the end of the case. You give protamine, the pressure drops a little. Oh, they vagaled when I pushed on the groin. There's all these other things we blame, particularly once the TE probe's out or the echo guy's going, if you're doing transthoracic. I think if looking at the tele would have been a giveaway in a couple of these cases. Usually you do see some EKG changes more than just heart block, like ischemic changes.
Yeah. Dr. Manigas asked about whether we would have seen it on TEE. We don't routinely do TEE for these cases, even the complex cases. But yes, I think you would. But you have to look for it. You have to look for coronary flow, so you have to have I think at the end of the procedure, everybody's focused on, is there leak? Is there paravalvular leak? Is the LV function look okay? And is there pericardial effusion? But when we used to do TEE a lot more, there is a workflow, and part of that workflow would always be, check the ascending aorta, check the arch for dissections, but look at coronary flow too. Colin, how many of your cases are you doing with TEE?
Yeah, I think as you very, very rarely, you know, if it's something, I mean, and I think most of us are now, you know, sedation and transthoracic echo. We will do a TEE, you know, as in that first case, if it's something particularly, it's a younger person, particularly complex. And I think if you're going to do Basilica, I think you need TE. You know, there's certain things like that, and mitral procedures. We haven't gotten brave enough yet to do mitral cases without anesthesia and a TE.
Yeah, absolutely.
Thank you, Dr. Barker. I just have a follow-up question about that last case that was very similar to Dr. Latif's case. Since this seems to be, you know, not the rarest of complications, has there been any thought about taking these measurements beforehand? I presume we know the height of the annulus on the core valve, and knowing coronary heights, and, you know, going into the procedure saying, you know, I want to implant this valve no higher than 2 or 3 millimeters because of this issue. I mean, is that something that's been done? I don't think we routinely hear, but you know, seeing these two examples.
No, that's a great point, and the answer is yes. You know, I mean, we do, you know, the sinus diameter and the coronary height are the two, and now kind of leaflet length are things we look at to try to predict the potential for coronary occlusion. And I have, and, you know, we both, Azim and I have proctored for various companies and devices, and have had this specific question. And I am more comfortable now about saying, you know, if you're okay with the higher rate of potentially needing a pacemaker, then deploying a little deeper, you shouldn't have a problem with coronary obstruction, unless there's something entirely prohibitive, which does come up every now and then, you know, really effaced sinuses with a low coronary, particularly in valve and valves. But yeah, that's a great point, and that is addressed.
I mean, obviously we look at it. And in this case, we considered whether to put a balloon expandable valve from the beginning. But it would have been a 20 millimeter balloon expandable valve, which we try never to implant because of the high gradients. And if you look at our implantation height, it was actually fine. If the valve had stayed at that implantation height, okay, there wouldn't have been any issue, but the valve popped up. And when the valve popped up, that's when we got into trouble. Part of why the valve popped up, I didn't show you the CAT scan because I really wanted to concentrate on that picture, was that the patient had a large septal bulge. And so I think as we released, the septal bulge actually just pushed the valve up slightly and it popped up. But I think it's something you should not have surprises in structural cases and TAVR cases. We try to avoid surprises by using our CT beforehand. There was a question here from Mohammed Ali, Colin, about how you snare a core valve. I mean, what are the steps? Is there any specific type of snare that you use? If you could just briefly tell him how you snare the valve in this case.
I mean, I don't think it matters. We tend to use the end snare. You know, the end snare or gooseneck is fine. I don't know if again, there's a whole lot of science to it, but I, for some reason, prefer to grab first the tab on the greater curvature, you know, to try to pull it off to maybe minimize an iatrogenic type A. We used to go in kind of femoral radial and grab both tabs and try to pull them together. But I think if you go in as both our cases showed, in kind of an emergency and grab that greater curvature tab and pull, there's less chance of injury. But what you may or may not have noticed, when you do pull, there is some rotation to the valve. It ends up, you grab it from the greater curvature and it ends up on the lesser curvature because it spun a little. And so that's why sometimes people like to grab both tabs to try to minimize that.
Yeah. I mean, I like the end snare too. I think it's better than a gooseneck because, so the end snare is like a 3D snare. So you have 3 loops. And when you're in an emergency situation, Mohammed, you grab what you can, is what I learned. You take what you can get. Is wherever you can grab the valve, grab it and pull, because it'll be enough to embolize the valve.
It's amazing how easy it is to pull it out, actually.
It's kind of worrying, isn't it?
Yeah.
I was thinking about your first case too, about the valve that went up into the aorta, that embolized. I think you mentioned one of the most important things is maintaining wire access through the valve. It's happened to us before, many years ago with an Edwards, where we lost wire access and the valve flipped around, and was the wrong way. And that's a huge problem. Because now you basically obstructed the abdominal aorta, and now you've got to try and pass the valve, through the leaflets and stent the valve open. One of the things we've done in a similar case like yours, Colin, was to try and move the valve into a safer position. Is we've taken a balloon, a BAV balloon, the size of the valve is slightly bigger, and try to inflate it inside the valve, right? So now you're grabbing the valve, and then to slowly pull both through the arch into the descending aorta, because basically you just want to get it away into the descending aorta, and you want it to stay in the correct direction that it allows flow. So that's worked for us as well. I hope I never have to do it again, though. So, but that's another trick you can use in that situation.
Great. Thanks, Azim. I'm going to have to run, but I appreciate it.
So much.
Really excellent.
That was great. It was so much fun. Thank you for sharing those complications with us. We really appreciate it.
Thank you, guys.